lithium blood levels so we could dialyze.
Okay, looks like potential overdose on lithium. Group 9, what else? What other problems do you guys have?
And we said that he had the symptomatic hyperkalemia with those increased T waves, so we gave him calcium, insulin plus dextrose, and dialysis.
Okay. How about group 2?
No.
We said he had uremia with BUN of 86, and we said dialysis was a solution.
Okay. And how about group 26?
But he had low bicarb.
Okay. So low bicarb probably has a metabolic acidosis. And if you guys remember back to Dr. Brandon's lecture with the mud pile, probably related to his acute kidney injury. Okay. How about group 19?
Oh my God. Say elevated serum creatinine, but we don't have a baseline value, so we don't have He had an elevated serum creatinine, but we didn't have a baseline value, so we weren't sure if the trend was secondary to
Okay.
And that would be an
So it's good to see that it's elevated, but somebody without knowing what their past medical history is or what their baseline creatinine is, hard to actually assess that in the grand scheme of things. How about group 3?
Good job, yeah, you're right. Y'all typed it, I just read it.
We noticed that their creatine kinase was very elevated, but we didn't really know how to treat that.
Okay. So I'll say these are all the problems that I hear you guys address. Some of these things you guys have already alluded to, but I also have some other comments in terms of things to address or at least consider. So group 20, when you hear that somebody has overdosed, we heard that the patient obviously had a bottle of lithium with them and they have an elevated lithium level. What other things may you consider in terms of helping this patient?
Dialysis.
Okay. You were group 20? I'm sorry, I forgot.
Yes.
Okay. Group 15. Anything else you want to know or consider in terms of helping this patient related to the overdose?
How long since the overdose?
Okay, so maybe how long ago, right? And I think Dr. Smith probably alluded to some of this stuff, right? Very few times patients only take a single drug, so you always want to know what all did they take first, right? So not only do you do a urine drug screen, but you're going to take a Tylenol level, you're going to get an aspirin level, an alcohol level, you're going to do all these different things. But as you're sorting through what they potentially overdosed on, certainly this patient overdosed on lithium, and in this particular case, lithium is a dialyzable drug. But if they overdosed on, I don't know, some beta blocker, right? Not all beta blockers are renally cleared or cleared by dialysis. So if they overdosed on diltiazem or lisinopril or whatever it may be, those things may not necessarily be dialyzable. So as you look at drug toxicities and drug overdoses, it's important to know what drugs they took and that you're considering trying to remove. It's also important to consider if you're going to diet. So everybody's talking about dialyzing this patient. So group 8, if you were going to dialyze this patient, any idea what type of mode you would use?
We would use intermittent hemodialysis.
Okay, so intermittent versus continuous. So you chose to do intermittent. How about filtration versus hemofiltration versus hemodialysis?
We would need dialysis.
Okay, so when you look at all of those different modes of renal replacement therapies, if you know that your purpose of starting this is to remove toxins that you know that your mode has to end in a D, right? It's got to be a dialysis mode, not just a filtration mode. How about group 17, with related to the uremia and the AKI?
What was this like?
How do we fix this?
I
You
guess
can obviously do dialysis like someone mentioned.
discontinue any.
The dialysis will specifically remove the elevated BUN. What else can we
He's
do
not
to help
taking it.
mitigate this patient's kidney injury?
Is he symptomatic when it's situated?
He's asking what else besides dialysis?
Yeah.
We're not sure.
We're not sure. We just dialysis.
Okay? So you will have lots of patients that you will see over the course of your career that have an acute kidney injury, maybe on top of CKD, that have an elevated urea, and not all of those patients you will dialyze. So certainly dialysis is a great mechanism to treat these patients. But it's good to also know that you have some other tools in your toolbox to help mitigate some of the issues associated with it. So how about group 24? What else do you guys think you could do for this patient related to their issue?
We would need to know the protein intake, because if they were having the protein intake, then we would not do the renal replacement therapy, but if they were, we would do it.
Can you elaborate a little bit more on protein intake?
Yeah,
The two.
based on whether or not you are
I just want to make sure I understand your answer before I respond to your answer.
Make sure he's adequately hydrated and everything and perfused.
We changed our mind on that maybe, and we think that we should maybe assess their hydration.
Okay, good. Yep, so the reason I asked, I just want to make sure that the slides for the free class material were clear regarding protein. So certainly we want to feed patients when they're in hospital, and the type of food that you give them or the amount of protein you give will be dependent upon if you do or do not initiate dialysis. So I wanted to make sure that was good. So you certainly want to control their blood pressure, make sure you are perfusing their kidneys, but you don't want to hyperperfuse, right? Because high pressure situations can certainly be stressful, including your kidneys. This patient's got some amphetamines in his system, and you see that he's extremely hypertensive. Remove any offending agents that may be causing the issue. Again, we don't know if it's drugs or what it is specifically related to his kidneys. I think group 24, you guys mentioned hydration. So certainly they could be hypovolemic related to their acute kidney injury. And as they become oliguric or anuric and they lose their ability to make urine, they then may become fluid overloaded, especially in the patients that you end up not dialyzing. You certainly run the risk of fluid overload and lots of complications associated with that. So it's good to evaluate the patient related to their kidney injury, whether you need to give fluids, remove fluids, or at least keep a keen eye on things. And then as we'll talk about in a minute, removing CK, somebody mentioned their creatinine kinase was really elevated, and then again their uremia because they are actively symptomatic. How about group 11? Group 11, tell me, so there was the mention of an elevated creatinine kinase, and there was mention that we knew it was elevated, but we weren't really sure what to do with it. So rhabdo, by definition, is a CK level greater than 5 times baseline, right? So that's really only a level of 4, 5, 600. The mortality rate of a patient that develops rhabdo, they have about a 4% chance of dying from it. But if your rhabdo ends up causing or contributing to an acute kidney injury, your risk of death goes up to about 40%. Right? So somebody with rhabdo, we either want to prevent them from developing an AKI associated with it, or we want to rapidly correct, do what we can to mitigate the issue. So how about group 8? Tell me what we can do for this patient's elevated CK and rhabdomyolysis.
We can give them bicarb.
Okay. Group 11, anything else?
We could possibly do a crystal load as well, so either lactated ringers or plasmolite.
Okay, so I love the fact that you did not say normal saline. I would be telling you a very biased response if I said to use LR plasmolite. The two fluids that have specifically been studied for rhabdo are bicarb and saline. So about 10 years ago, there was a study comparing these two fluids, and they actually stopped the trial early because bicarb was so superior to saline. And then just in 2017, the PRESERVE trial was a larger and more randomized control trial in New England Journal that compared the two and showed there was no difference. So it would be unfair for me to tell you not to use saline because it has been studied and shown to be equal, non-inferior to bicarb. There has never been studies looking at plasmolite or lactated ringers. I will tell you that that's what I would do, LR, or plasmolite or bicarb. In practice, I would not choose normal saline. But at least this is what the evidence tells you. How about group 12? Tell me about their hyperkalemia with EKG changes.
Well, they definitely have hypokalemia, so we're going to give them calcium, since it's cardioprotective, and we've got elevated T waves.
Okay, you going to do anything else for them?
Oh, we can also give them insulin and dextrose.
Okay, good. So you can certainly go down your algorithm here, remembering that the key points here are, one, when you have hyperkalemia, you have to get an EKG. You don't really know the most effective and safest way to treat the hyperkalemia without getting an EKG to assess for those peak T waves. It's a cute little algorithm, C big K drop. C is the calcium. That is only to be used if they have peak T waves. Right? This is a problem that you'll see in institutions over and over again. Somebody's got hyperkalemia. They just immediately throw every single one of these letters at them. And half the time, most of the time actually, calcium is not necessary. We had a patient yesterday or 2 days ago that had presented. They had missed a couple sessions of dialysis. They had a K of greater than 9. So the lab didn't even measure how high it was. It just said greater than 9. They absolutely had peak T waves. And they also had a glucose of 700 and like 746. That patient certainly got calcium, and they also gave insulin, but because they are so routine with giving insulin plus glucose, that they gave them both, and the patient's glucose ended up going up to 900. So it's important to remember that insulin is what treats the hyperkalemia. You only give glucose with it to prevent the hypoglycemia that will come with the insulin. Okay? So the glucose is not necessarily to treat the hyperkalemia. It is not always required. Most of the time, yes. But in certain situations, like what we had a couple of days ago, it was unnecessary and actually worsened the patient's DKA.
Dr. Hawkins, I have a question.
Yes, ma'am.
Around what glucose level medication would you suggest not giving the D5 or the dextrose?
Yes.
That is a loaded question. Do they have a history of diabetes or not? Has their body, like, are they insulin sensitive or are they insulin naive? If they're on insulin at home. So normally I would say if it's over 250 to 300, then I would say I would not worry about it. Anything, if I don't know anything about the patient. That's probably the safest answer. I would never test you guys on that either. But in clinical practice, it's going to be dependent upon if they take insulin at home, etc.
Thank you.
Any other questions before we go to the next slide?
With the B for the beta agonist, if you were to use the albuterol, when would you use it, and what would that look like using albuterol in that kind of situation?
When would you use it? is, I mean, at any point in time, you can use it as your cocktail to treat hyperkalemia, especially depending on how high their K is, symptomatic, if they're in VTAC and you're waiting on dialysis to come up, etc. What does it look like? You would not use a metered dose inhaler. You would use a nebulized solution. And normally it's going to be like if every patient over there right now on the ventilator is on albuterol nebulized solution of 1.25 or 2.5 milligrams of albuterol, and it's like every 6 hours. This patient, if you were to give albuterol, you would give them like 10 milligrams of nebulized albuterol like every hour, or following their serial potassiums and continuing to treat as necessary. Is that the kind of answer you were looking for? And are there any other questions?
Yes, thank you.
Okay, good. So I will try to beat this till it's a dead horse so we can make sure we all understand indications for dialysis. So general indications. So group 18, tell me the little alphabet soup and what they all stand for.
Okay, AEIOU for acidosis, electrolyte abnormalities, intoxication, overload, or uremia.
Okay, good. So group 21 so now we're going to take this general indication, right? Because we talked about the patient and we talked about the problem that he has. Some of those include dialysis and some don't. So the question is, you may have to treat some of those problems assuming you're not going to dialyze them. So group 21, does this patient have acidosis? Do they have this specific indication to dialyze?
Yes, they do have acidosis.
Okay, so how did you come up with that?
The ion gap is 23.
Okay, so you guys went above and beyond to calculate an anion gap, right? So I will tell you that to determine if they have an acidosis, because there could be a lot going on physiologically. The only way to know if they have an acidosis is to see what their pH is. Okay. I would agree with you. This patient, I'm 99% sure they have an acidosis. But this would be a great person that you could recommend to get a blood gas on so you could assess the full picture, right? So when you look at the acidosis and you look at dialyzing the patient, would dialysis correct a respiratory acidosis or a metabolic acidosis, or both, or neither? I'll keep this with group 21 since you guys are off the charts calculating anion gaps over here.
Wait, he said
No.
They
stopped to study it. So the only ones that actually studied are studying Sodium and bicarb, but they stopped to study early because bicarb is so much better than sodium.
Would it take care of the metabolic acidosis primarily?
Okay, I'm going to take that question and turn that into that is your answer. That,
Yes.
okay. Yeah, so, and I say this specifically because I think next week Dr. Newsom is going to teach you about acute respiratory failure, and you will hear that there is hypercapnic respiratory failure where patients present with a respiratory acidosis. Right? Dialysis cannot fix a respiratory problem. Dialysis only fixes a metabolic problem. So a pH by itself doesn't necessarily tell you if you should dialyze someone, but it's specifically what type of acidosis they have. And I know Dr. Brandon already talked about the metabolic and respiratory and gap and non-gap, etc. How about group 10? How about electrolytes specific to this patient?
He should be dialyzed because he has hyperkalemia.
Okay, so we have hyperkalemia. Now, there are lots of electrolytes when you look at a patient's labs that you could say, oh, this patient's, sodium is extremely high. Would you dialyze a patient because they had extremely high sodium? So the only electrolytes that dialysis is specifically indicated to treat is hyperkalemia and hypercalcemia. Right? Malignant hypercalcemia, especially in patients with malignancies, and then hyperkalemia. So if somebody came in and they said, oh my gosh, this patient's serum phosphorus is 15, it is critically high. That is very true. But if they didn't have any other specific electrolytes that were life-threatening, like calcium or potassium specifically, you wouldn't do it. You wouldn't necessarily dialyze them. For intoxication, how about group 13?
Yes, he has intoxication of lithium, which is renally cleared.
Good. Yep. So specifically with this patient, we know that he at least has lithium. We don't know what else he has, but we at least know that he's got that much. Group 16. What do you know? How about fluid overload?
His blood pressure is high, but we don't know if he's responsive or not.
Yep, so we don't really know anything about his fluid status. So again, that kind of goes back to what we talked about. Maybe this patient needs to be fluid resuscitated in addition to dialysis. Or maybe he does in fact have fluid overload. So we'll probably have to do a little bit more investigation in terms of the patient's physical and clinical status. How about group 23 related to uremia? Yes, he has uremia. So what about his uremia tells you that this patient needs dialysis because of his uremia? And I say this because I've seen a patient with a BUN of 150 that nephrology decided not to dialyze. And I've seen patients with a BUN of 85, like this patient, where they did decide to dialyze.
Is he symptomatic or not?
So group 1, help them out. What are some symptoms? What would a patient look like if they had symptomatic uremia? And group 23, y'all can chime back in too.
Uremic encephalopathy, pericarditis, and bleeding risk.
Right, so the big problem with uremia, right, I've seen patients intubated because they were so uremic that they were so altered that they could not protect their airway. Right, so this patient, now granted, he could easily be toxic from opioids and all types of other things he could have potentially overdosed on. But at least right now we know that he has an acute uremia and that up in the mid to high 80s, 86 or 82. And he is encephalopathic. So that, because he is encephalopathic or unresponsive, that would be the indication specifically related to his uremia. If somebody had uremic pericarditis, that's probably not something you're going to dialyze for. You can treat pericarditis with drugs, and you can probably diurese them. And then uremia-induced platelet dysfunction or bleeding diathesis is a complication associated with uremia, but it's not, it's not an indication specifically. So when we say uremia as an indication for dialysis, we're looking specifically for uremic encephalopathy. Okay, so next day, patient tolerated 4 hours of intermittent hemodialysis. You see his new vitals and labs below based on lithium level. The ICU physician and nephrologist agreed to do another round of dialysis today. So what problem may you encounter today? What would you expect? And is there anything that we can do to prevent this? So I'll give you guys a few minutes to talk amongst yourselves.
because he's already hypotensive and his potassium's getting low too. And his lithium's fine. His lithium, right?
I think he was there too.
Okay. So we should do like a continuous instead of intermittent.
So group 11, what do you guys think? What problem would you expect to encounter?
He's hypotensive.
Okay, so because he's hypotensive, that would make you think that what is going to be a problem?
Low perfusion.
During
Dialysis.
dialysis. Okay? So what did you do to prevent this?
Maintain and monitor fluid status.
Monitor fluid status. Is there anything we could do about the type of renal replacement therapy we give?
Could do continuous.
Okay, so you'd probably switch to continuous, right? You would also continue the bicarb infusion because you see his CK is still really elevated. That doesn't have to do with his blood pressure and his dialysis, but you would still continue that. So this is really important, right? Somebody is, if you look at the difference in intermittent hemodialysis and continuous of anything, whatever mode you're in, intermittent is going to take a bunch of blood out of the patient and dialyze it over a 4-hour period, right? So they pull out a lot of blood at once, and they clean it, and they put it back in. But while they remove all of that blood, the patient experiences hypotension. And if they're already hypotensive, they're not going to be able to tolerate it. So a normal intermittent hemodialysis session is about 4 hours. This patient would probably tolerate about 30 minutes of it, and they wouldn't be able to effectively remove the lithium. So instead, what you would do is do some type of slow continuous, so that you can remove the same toxins, but instead of removing it all of that blood at once, instead of over 4 hours, you do it over 12, 24 hours, etc. So this is the patient we're going to switch over so that their blood pressure can better tolerate it. So, general considerations in drug dosing, right? Now this, I said intermittent hemo to CVVHD. It's not just CVVHD that these things apply to, just very general principles. Are you doing intermittent or continuous? Right, and that tells you a little bit about their blood pressure. It tells you a little bit about drug dosing, right? Somebody's getting intermittent hemodialysis. Any drugs that are renally cleared, I can probably just schedule right after their dialysis session is complete. If it's continuous renal replacement therapy, then I can't just schedule something after dialysis because it's going to be going around the clock. So instead, I'm probably going to have to dose things more aggressively because I know that the machine is going to be cleaning it out as I'm giving it. Also, what specific mode are you doing, right? So in this patient, we're doing intermittent versus continuous hemodialysis. So I'm not just removing fluid, right? I'm removing drugs and toxins, right? So if I put this patient on CVVH, I would probably not have to renally dose any of their drugs because I'm going to be removing only fluid, no drugs. CVVHD, I'm going to be removing drugs. I'm going to have to go look up what type of drug it is, if it's renally cleared, and then renally dose adjust based on what mode they're in. Something I just alluded to is even related to the patient with overdose, right? Just because you're on renal replacement therapy doesn't mean you're going to suck every drug out of the patient's blood that they're on, right? Lots of drugs are not renally cleared that you don't renally dose adjust. So it's important for you to look back and look up the drugs and see which ones you do need to pay attention to. Again, I'm not going to give you a patient's drug list of what they're receiving and ask you which ones you need to be concerned with. Certainly, I don't remember those things. Most people won't. You just have to look those things up as the questions arise. What's the filter size, right? So this is something that's a little bit more nitpicky, not something I would ever ask you to know, but it's general principle of things. You need to know how big your filter is in your dialysis machine to tell you what size molecules and drugs that you can clear. Okay, when I was a resident, I did rotations at Emory Main Campus on Clifton Road and also at Emory Midtown. Emory Main Campus, a normal dialysis session would remove about 30% of the patient's vancomycin. I could check a vancomycin level before and after dialysis, and a single dialysis session removed about 30% of their vanc. I would go to Emory Midtown for a rotation. They do the same dialysis with the same nephrologist doing it, but they use different filter sizes, and that same dialysis session would remove about 50% of the vanc. You come down here to Phoebe, you get a vanc level, you give them the same 4-hour session of hemodialysis, and their filter size is a lot smaller. It doesn't remove a single bit of vanc, right? So it's hard to know how to dose vancomycin or any drug on dialysis if you don't know the filter size, right? Or if you ask, generally speaking, who's been working there before you, if they have an idea already. And then lastly, and then this is a lot more nitpicky only for folks that are going to be in the ICU all the time. For continuous renal replacement therapy, because you only do continuous in an ICU, you're not going to see anybody on the floor or outpatient getting continuous. If the patient is getting continuous renal replacement therapy, you can look at how fast they're running fluid through the machine, and you can actually calculate the creatinine clearance of that machine. There's some nice review articles in the literature that look at different modes, different flow rates, and it tells you common drugs that are being dosed and how to dose them appropriately based on different flow rates of different modes. We good? Any questions on this before we go to the next patient? Or the next day, a few days later for the same patient? Okay. So here we see the patient 4 days later, still unresponsive. He's been off renal replacement therapy for a couple days, been off fluids for a few days, etc. So I'll let you, this guy's going to go down. We still don't know what's wrong with his head, right? He's still unresponsive. So we're going to go down and get a head CT with contrast. We know this patient is at risk because he has previously had renal insufficiency. So I'll give you guys a few minutes to discuss what we want to do for him. Be specific.
Sorry.
Why are they doing that?
Oh, I think it's white font. Yeah.
White font?
Like it's white on the slide. Oh. Like on his PowerPoint, it's like in white font. So when I was pasting it.
Okay.
Okay. Group 22, what do you guys think? What can we do to prevent this guy's contrast condition dropping?
We would hydrate with bicarb 3 mils per kilogram per hour, 1 hour before and during exposure, then 1 mil per kilogram per hour, 6 hours after exposure.
Okay, good. So I'm going to take that answer, and like if you were the person recommending that or making sure that you did it, if you know that they were going down for the contrast at 1400, right, you would have to put in the fluid to start at what time and end at what time. So I'm not going to ask, I mean, you don't have to tell me, but just putting it in, like conceptually, this is what you guys would do is related to as the pharmacist. So in, way back, you saw he was 220 pounds, so he's 100 kilos. So this is a dose, so I normally don't ask you guys to remember doses, but doses of fluid to prevent contrast, I will ask specifically because physicians get it wrong every single time, right? So as a pharmacist, not only can you identify patients at risk for contrast nephropathy, you can specifically recommend the fluid, the timing, and the dose of the fluid because they will always be so scared of it that they're going to give way more fluid than they should. And we know from a few weeks ago that there's lots of bad things associated with fluid overload and giving too much fluid. So one thing I realized, I think I told you guys this whole story about bicarb versus saline and what's in the literature and previous studies conflicting with studies 2 years ago in the PRESERVE trial. That was related to contrast. I think I said it earlier related to rhabdo. That was my mistake. In rhabdo, like we talked about for the first patient, you can use bicarb, saline, any crystalloid. In contrast nephropathy, this is the one where specifically bicarb and saline have been studied. At first, bicarb was shown to be superior, and then most recently in the New England Journal paper, they were shown to be similar. So again, the same argument still applies. I still prefer bicarb or some other balanced solution, but if you choose saline, you are absolutely not wrong. So group 25, if the physician insisted they don't want to use bicarb and they wanted to use saline, what dose of saline would you give?
We would not do saline due to their hyperchloremia.
Okay, good. Right, so hyperchloremia, so in general, saline would be okay. In this patient specifically, not a chance. Right, they're already probably got some non-GAP metabolic acidosis, and we're only going to worsen that. All right, here's one for you guys. I'll let y'all read through this and look at some things to consider, and we will come back in about 6 or 7 minutes. Okay. So, hopefully you guys have been able to look over the guy's history, some of his labs, and try to figure out what's going on. So before we get to the nuts and bolts of this patient in particular, it's first good to kind of talk about what you would expect in these labs to help better assess. So Phoebe, if this patient had another renal stone, would you expect his FeNA to be up or down?
Greater than 2%?
Okay, so you would expect this FeNA to be high, greater than 2%. How about group 4? What do you think about their FeUrea?
If that was a stone, would it be greater than 50%?
Okay, so definitely elevated, definitely above the 35%. If they were over-diuresed and hypovolemic, group 4, what would you expect the FeNA to be?
Less than 1%.
Okay, so it would be low, less than 1%. And what about the FeUrea?
Less than 35%.
Okay, so if they were over-diuresed and hypovolemic, their FeNA and their FeUrea would both be low. How about group 7? If they were under-diuresed and they had cardiorenal syndrome, what would you expect the FeNA and the FeUrea to be?
Less than 1% and less than 35%?
Okay, so they would both be low. So this is a very important take-home message, right? If you, just by looking at these lab values, if their FeNA was low and their FeUrea was low, it tells you that it's pre-renal, right? One of those pre-renal possibilities is that he is hypovolemic and we should give fluids to him. On the other side, if you misinterpret and you give him fluids and he's under-diuresed with cardiorenal syndrome, you could potentially kill this guy, right? You put him in flash pulmonary edema, require him to be intubated, etc. So it's important to look not just at the numbers, right, but at the clinical picture so you can get a better idea maybe of his volume status. So what did you notice about his FeNA and his FeUrea, group 14?
The FeNA is high and the FeU is low.
Okay, so tell me more about that. Can you draw any conclusions from that information? Maybe that's a better, more direct question.
Well, with low Fe and A, we would expect, to be pre-renal. It's above 2% or so, intra or post-renal for the slide. So just looking at the numbers, you could just sort of glean whether it's pre-renal or post-renal or not, and therefore we can guess whether it's, a stone or something else, right?
Yeah, so if you look at the FeNA is high, right? So the FeNA is above 2%, so that tells you that it's not pre-renal.
Thank you.
And if you look at the FeUrea, it is below 35%, which tells you that it is pre-renal, right? So these two numbers are conflicting. They're not telling you the same. They're not giving you the same information. So the question to you guys, and I'll let you ponder this, why are they conflicting? And I'll tell you it's specifically due to one of the patient's medications. right? So this happens all the time. People love to order these tests, or at least one of these, and they don't know how to interpret it because of the patient's medication profile. So of the drugs that the patient is on, which of them do you think impacts FeNA? And I'll give you guys a minute or two to think about that. Just thinking about the mechanism of action.
Lasix, because it increases the sodium. Right? Yeah, but sodium more so. Because if the Lasix put more sodium in the urine, the top number would be bigger than it should be proportionally. And so it would look like it's post-renal. It goes over 2%. Does that make sense? So like Lasix puts out a lot of sodium in the urine, so that's the top number.
Yeah.
So if that was higher proportionally than the sodium in plasma, which it would be, then it would make it look like it's higher, like so it's probably pre-renal. So it's probably like the cardiorenal.
Kendall, what's wrong? Are you dying? What's happening? Yes, I'll send it to her.
Oh, sorry, I didn't mean to.
Yes, you did mean it. That's what you did.
I'm gonna get you a face.
He hit me in the face yesterday when I was driving.
Oh my god, that's dangerous.
Then you were doing this, and so I just did it like that.
I was singing a song, so I was like, and then he comes and just pops me, and I was like,
Oh my god, that's funny. I've done that so many times though. I'm like, oh, sorry. It wasn't supposed to be that intense. Sorry. I felt like a misperception.
So group 5, what do you guys think? What drug do you think may be causing this conflicting thing, and what would it do to your FeNA?
Just a moment.
Okay.
Had a moment.
Group 7, I'm coming to you next, so be thinking about this as well.
Okay, so we weren't totally sure, but we were thinking maybe Lasix.
Okay, so tell me why you were maybe thinking Lasix. You're not sure if you're right or wrong, so if you got some good hypotheses going, so I want to hear what you got.
Right. So, well, hopefully. So we were thinking that potentially the Lasix could cause his urinary sodium levels to be higher, which would increase that FeNA because it would increase the sodium level in the numerator. But we know he is not urinating, so we were a little stumped, but that's where our thought process was going.
Okay, good. I would say you're right on the money, right? So Lasix has a loop diuretic, acts in the loop of Henle. It specifically prevents sodium reabsorption. It makes you pee a whole lot of salt so that water follows. So even though he doesn't make a lot of urine, his urine is going to be extremely salty, right? A single dose of Lasix can make your FeNA go up to 25%, right? Doesn't have anything to do with what your kidneys are doing or what your volume status is or why you have an AKI. But just because of the way Lasix works, it will make your FeNA be up to 25%. Okay? So, in this case, FeUrea is the only thing that is actually going to be reliable. But when you see that the FeNA is high, you have to ask yourself, is the Lasix actually interfering? So group 13, do you know how long ago the patient should have taken his Lasix for it to still interfere? Basically, how long Lasix works in your body?
6 months.
All of this stuff, like from fluids to this, should have been the first thing put on therapy. Because it's like
Approximately 8 hours.
electrolytes didn't make sense.
Okay.
until
So
neither
might be
did
a little bit of a
Lasix.
generosity for Lasix. So luckily the people that come up with the drug, they were very clever when they gave it its brand name. So Lasix lasts 6 hours. Right? So you as a pharmacist should never verify a Lasix order that's given any more frequently than Q6. Now granted, Q8 is probably more reliable, at least in the inpatient setting, or so you don't overdo things, but I have definitely given Lasix every 6 hours. So you look at his FeNA and FeUrea, you look at what time it was drawn and calculated, and you just make sure the patient did not get Lasix within the past 6 hours. Unfortunately, the patient took his Lasix dose only 3 hours before, so we know that his FeNA is high specifically because of his Lasix. So now that we know that the FeNA is unreliable, we can only go by the FeUrea. So with the FeUrea being low, we have said that now it's not a stone, right? It's not intra or post. We know it's pre-renal. So knowing that his FeUrea is low, do you guys think he is over-diuresed and hypovolemic, or do you think he's under-diuresed and has cardiorenal syndrome? So group 7, what do you guys think about that? Know that it's pre-renal. Is he fluid up or fluid down?
Since he hasn't been healing, wouldn't he be fluid up? Even though his blood pressure's low, just wait until he has a compartment. I'll add a bunch of it in there.
Does he have any?
It doesn't say.
Fluid down.
Think his blood pressure.
Okay. Group 3, agree or disagree?
Yeah, no, there's a
We agree.
short of breath.
Okay.
It's probably fluid
So
up.
group 7, tell me why you think he's fluid down.
And it's just like partitions or compartments that it was massive.
He's hypotensive, so he's probably been over-diuresed.
Okay, so you think he is hypotensive, or because he's hypotensive, that's telling you about his volume status.
Oh, God.
So a lot of things can cause low blood pressure, right? He was on Coreg and everything at home. He could have just taken his blood pressure medicine. If you look at his chest X-ray from a couple slides ago, what does his chest X-ray indicate that he's fluid up or fluid down?
Up. It's all white.
Yes.
Well,
Back to you for three.
Big blob in the middle of the heart.
Yeah.
That stuff should be black. Like you should be able to see like degree.
Maybe you guys need to frame it right. You go to Google and type in clear chest to see what happens.
It's just a big gobble of water, just sitting where his heart sits.
Teardrop worth of water. Like, does he have pneumonia? And so he has like fluid in his lungs from an infection. That's why he was like, and his injection vaccines we don't take like away. Stuff isn't going where it needs to.
I think the primary intervention is.
His lungs look cloudier than the clear ones that we Googled, so maybe it's an overload.
Okay, good. Yes, so this patient is probably under diurese, and he has a CHF exacerbation, and he is fluid overloaded, and he needs fluid to be pulled off of him. His blood pressure is probably low because he's in some degree of cardiogenic shock potentially, because he's hypotensive. Maybe we need to hold his blood pressure meds, and we need to get his heart. I mean, you see he's got an ejection fraction of 15 to 20%. So his heart is not strong enough to generate a normal blood pressure at baseline. So the team plans to treat his cardiorenal syndrome, so they can hold his blood pressure meds. Like you said, he's hypotensive. We're going to give him an inotrope and a diuretic to help improve his heart, his cardiac contractility, and then we're going to give him a diuretic so that his heart can effectively deliver the loop diuretic to his kidneys. Or if he's anuric and we give him the inotrope and the diuretic and it's not working, we could also do renal replacement therapy, because we know this patient specifically is extremely fluid overloaded. So if we know that our goal in him is to remove fluid, right, AEIOU, fluid overload, and he doesn't have any other real indications for dialysis, right? He doesn't have any drugs that we're trying to remove, nothing like that. So if we're going to start him on renal replacement therapy, what modes would be appropriate? So maybe a mode that's going to remove fluids, but not drugs and other materials. So how about group 17?
Hey! Scuff.
Ma'am?
Scuff, S-U, or S-C-U-F.
SCUF, okay, SCUF, slow continuous ultrafiltration. It's literally a machine that acts as a diuretic. All it does is pull off fluid. Group 15, is there another potential dialysis mode you could do? I say dialysis mode, renal replacement mode, not dialysis.
We do CVDH.
Mm-hmm. Could you expand on that question for us?
What is another mode of renal replacement therapy that removes fluid but not trash? So a renal replacement mode that is not dialysis.
One of the 3 filtration modes,
Oh my god.
Was that a
like intermittent ultrafiltration or slow continuous ultrafiltration, or the CVVH.
Right, or CVVH. Right, so it's important to remember, relatively speaking, if it does not have a D in the acronym, it does not have dialysis. It's only going to remove fluid. Okay, so SCUF, CVVH, intermittent ultrafiltration, IUF, those 3 would be reasonable. And you could, you specifically would not do anything intermittent because it's probably going to drop his blood pressure even further. Right, so anybody that's hypotensive, you want to avoid anything that's intermittent and stick only to continuous. So let's say we start him on SCUF. Would you change the doses of all of his renally cleared drugs that the patient was receiving?
No.
How about group 9?
yeah, we would adjust according to the levels.
Okay, so what if it's Zosyn? Zosyn is a renally cleared medication that the patient is on, and we do not check Zosyn levels. There is no therapeutic drug monitoring for Zosyn. Certainly if it was Vanc, we could absolutely follow Vanc levels. What about Zosyn? And I only ask that because only about, 10% or less of the drugs that we give, we can actually monitor levels with.
We would either switch it or maybe avoid nephrotoxic drugs.
Okay, so you're taking the route of I want to not cause kidney injury because he's on dialysis. Or he's on renal replacement therapy. So what I'm focusing on here, we are giving this patient SCUF or CDVH. It does not have a D in it. So it does not dialyze, it does not remove drugs. So if this patient was put on SCUF or CDVH, you would not care about renally dose adjustment, right? Because the dialysis mode is not going to remove those. Now you can look at the patient's serum creatinine and you can calculate his real creatinine clearance, and you can dose him from that reason, or from that regard. But his renal replacement therapy, these two specific modes, you're not going to be concerned about drug removal. Now certainly if this patient had an AKI and you were looking at then what you suggested in terms of monitoring drug levels and changing to other appropriate therapies that are less nephrotoxic is also certainly appropriate. But just related to renally dose adjusting based on the mode that the patient's on. Right, and this is important because a lot of times what you're going to hear is somebody say, oh, the patient is on CRRT. Right, we had a patient a couple days ago that we put on CRRT. He was on 3 pressors. He had creatinine of 4, a BUN of 150, and he was just intubated, and he was on his death. I actually was surprised he was alive when I came in yesterday morning. And so they started him on, if you ask the team, they would tell you that they started the patient on CRT. So the pharmacist downstairs took all of his Vanc and Zosyn and everything else and changed it over to make sure that they dosed it appropriately based on CRT, right? As if he had severe renal injury. But the patient was actually getting SCUF, right? So they actually took his Zosyn and changed it to Q12. They took his Vanc and turned it into pulse dosing. But he actually was not getting drug removed because he was only on SCUF. They weren't dialyzing any drug off. But somebody gave them some generic term and said the patient's on CRRT. Patient being on CRRT doesn't tell you anything other than they are probably hypotensive and in the ICU. If you know that a patient's on CRRT, your very next question should be, what mode? Okay? Otherwise, you can't make any clinical decisions just based on knowing that they're on CRRT. Before we talk about this patient, any questions so far?
I have one quick question.
Yes, ma'am.
I guess this is more of a question for just patients in general. Since that patient wasn't producing any urine, would we want to give them, would it be an option to give them a diuretic, or would we kind of just say since they're not producing any urine, we need to do renal replacement therapy? I know that's probably this patient's best bet, but I guess I mean just in general, if we have a patient not producing any urine, are diuretics ever an option?
So as always, I'm going to say that that's a loaded question. In this patient particularly, so I'll just address it with this patient, how I think about this. This patient has an ejection fraction of 15 to 20% or 10 to 15%. And based on what we talked about, they likely have cardiorenal syndrome. I can give this patient Lasix all day long, right? But Lasix only works if you can deliver that drug to the loop of Henle in his kidneys. So I can give him Lasix, and it will work if it can get to his kidneys. The problem is his heart is so weak that it can't deliver the Lasix to his kidneys. So if I'm going to give him Lasix and trust that it be effective, I'm going to have to give him an inotrope so that his heart can be strong enough to get the Lasix there. So would I give this patient Lasix? Yes, but only if it's in conjunction with, dobutamine or milrinone or some type of inotrope, maybe epinephrine. if his blood pressure or his hemodynamics or his arrhythmias or whatever couldn't tolerate an inotrope, then I know that if I can't give an inotrope, then a diuretic's going to be useless, and so that's when I'm going to give renal replacement therapy.
Okay, that makes more sense. Thank you so much.
Yes, ma'am. Any other questions? That was a good one. And related to that, I would never expect you guys to know how to treat cardiorenal syndrome. I would never expect you to know, at least for this particular lecture, how to treat hepatorenal syndrome. You'll learn that on Monday, right? But if I tell you the patient has cardiorenal syndrome, you should know, you should be able to identify that you should treat the underlying cause of their AKI, okay? Cardiorenal syndrome being the underlying cause. You don't have to know inotrope diuretic. Just know that you got to treat cardiorenal syndrome. Okay, so I'll give you guys 4 or 5 minutes. I'm going to make sure we have time to get through everything to work on this case. So I'll come back in 4 minutes at 10:31.
So I just said just like hydrate.
Yeah, since she's doing this one on
Oh, I thought that was add more fluid. Never mind. So would you give her a diuretic to do that? Like, would you want to match whatever with more fluid? Like, will we increase white feather ringers to like 100, and then also do a diuretic to match the rate out? Or would you even give a diuretic if you just give her more fluid? She's working.
She's already
Okay.
on her own, like without.
Or that's the ground glass. Show like a preparation strategy based on sulfama.
Increasing the lactate ringers specifically for sulfama prevention is just to maintain a urine output at 150. And since she's producing the same output that she's getting in right now, then we can probably just increase it. Yeah, just increase the lactate ringers just to maintain that. Since whatever she's putting out, or whatever she's getting in, she's putting out. Under the assumption that increasing it would increase the urine output. We don't know.
don't have the toxin. Just the platelet aggregation. Because like you have to get like a gram of aspirin to get the anti-inflammatory portion. It's just antiplatelet if you do 81 or 325.
All right, group 24, what do you guys want to do?
We would like to increase the fluids to maintain a urine output of 100 to 150 mils per hour because we don't want crystals to form in the urine. And then maybe switch from lactated ringers to bicarb.
Don't they affect
Okay.
any fear?
How about group 11?
Prostaglandins.
What you guys want to do?
Insects.
So we're here. So after patient's fluid status, we thought she was all right. Based on, I guess, what our research was, normally patients produce about 500 cc's a day, I believe. Right now, our patient is doing about 1,200. So we thought her fluid output was fine, but we're not wanting or.
Okay. How about group 5? Anything else? Or different than what's already been stated?
Yeah. We also want to increase her fluid to maintaining an output of 100 to 150 milliliters per hour, but we wouldn't switch to bicarbonate unless she shows signs of crystallization, since it's only used to alkalinize and dissolve the crystals.
Okay. Tell me your group number again. I forgot already. 5. How about group 1? Anything else?
We don't have anything else yet, and we agree with group 5.
Okay, so we've got a lot of folks that said they wanted to change their fluid to target a different urine output. There was some discussion about LR versus bicarb. Anything else from any other group?
We found in group 3 that the dose of Bactrim is too high.
Okay, so we got some folks here in Albany agreeing with you. So what would be the normal dose of Bactrim for PJP or PCC, whichever you looked at?
15 to 20 milligrams per kilogram divided into 3 to 4 doses for the day.
Okay, 15 to 20 mg per kg divided across 3 to 4 doses. So you don't even have to, you could calculate this patient's creatinine clearance if I gave you their weight, etc. But even without knowing any of that, you at least know that 50 milligrams per kilogram is wrong, right? So at baseline, you guys should definitely always evaluate a patient's drug dose, because that by itself could easily contribute to patients developing AKI. Right, so I would agree with you. So there was one group that said what's normal urine output and that they were making a normal amount of urine. I definitely agree that they're making a decent amount of urine right now, right, as a normal, healthy individual. Problem is this patient has PJP, they're on an extremely nephrotoxic drug. So our job is to maintain adequate hydration, actually overhydrate them to prevent crystallization of the drug. And so that's where we would increase their crystalloid to maintain a very aggressive urine output. So, all the pharmacists in the hospital noted to increase their LR, but did not appropriately adjust their Bactrim dose. So 48 hours later, her creatinine's 2.9, her calcium's 8.4, phos is 6.5. What can you do to help mitigate the progression? So how about group 18?
Give them bicarb so it doesn't crystallize.
We would still recommend lowering the Bactrim dose to the correct dose, and then we could maybe start bicarb to help alkalinize the urine and prevent crystallization.
Okay, so I would definitely switch the fluid to bicarb, like you mentioned, maintaining adequate hydration, etc. But specifically alkalinize to help get rid of those crystals. In this patient, you definitely would want to decrease the dose. But maybe even because now that they have an acute kidney injury, you may want to talk about what can we do to change the risk of nephrotoxicity from worsening, or to treat it by either switching the drug or at least switching it to oral because it's less nephrotoxic. So another discussion to have just regarding your treatment choice, your drug regimen. So the physician says, well, they got an AKI at 0.6 up to 2.9. Their phos is elevated. Phosphorus is one of the first things to, obviously your urine output will drop. Phosphorus is one of the first things that will jump in an acute kidney injury because it's renally cleared very quickly. And so any change in urine output, you'll immediately see their phos bump. So the physician asks you to order a phos binder. So do you want to order a phos binder? No. You haven't had CKD, ESRD yet, so you don't know about choosing different phos binders. But would you order a phos binder? Why or why not? You guys can think about that.
Also known as bone. Yeah, I know. Oh, yeah. We should not give her a phosphate binder because she has an acute kidney injury, not a chronic kidney injury.
Okay, good. What group are you?
18.
Oh, okay. Yeah, so this is very important, right? The reason you give phos binders, and again, Dr. Newsom will talk about this next week, you worry about calcium, elevated calcium and phos, and calcium phos product, because calcium plus phos, calcium phosphate, is also known as bone. Right? You leave a patient with elevated calcium and phosphorus longer term, and those things will crystallize and actually stick to various things causing calcifications. So phos binders are only when it's a long-term issue, not in the acute phase, in the acute setting. I'm not going to go over this, but this is definitely something you guys need to know in terms of how to prevent AKI and how to treat it, and specifically related to which types of drugs that you're concerned for. Now, this is in your pre-class material, but I just wanted to emphasize it. So last patient, we'll go through this pretty quick. 41-year-old male newly diagnosed with heart failure. They started on metoprolol and lisinopril. His creatinine was 1.1 at that visit. He comes to your heart failure clinic a few days later, and you see his serum creatinine is 1.4. What do you want to do? So I'll give you guys a couple minutes to talk amongst yourselves.
I will put him in the risk. Yeah.
But less than 1.35.
He wouldn't be able to do it.
you guys want to do for this gentleman?
So if it went up to 1.43, which it did.
We said we would either dose reduce or DC them.
Okay. So you would dose reduce or you would DC it. So you don't have too much opportunity to decrease it. You can go down to 5 or maybe you can cut it in half and do it 2.5 milligrams. So you would definitely have to, if you're trying to decide between the two, what dose are you currently at? What's the risk benefit? Does the patient have all these different comorbidities where lisinopril is necessary? Maybe you can do a trial of an ARB instead of an ACE inhibitor. You're probably going to get something similar in terms of the effects on the kidneys. So if his serum creatinine was less than blank, I would not make any changes. Right? So if you knew this guy was started with a creatinine of 1.1 the other day and he's coming in to visit, you can go ahead and get your head circled around what you're going to do when he comes in. Right? So group 20, fill in this blank here. At what serum creatinine would you not make any changes to his current therapy?
Less than or equal to 1.43.
Okay, good. Right? So you see somebody starting on lisinopril, you know what their baseline creatinine is, you can very quickly do the math, write that off to the side, and you can already have your mind made up, and that's your threshold. Right? You look down further either to the test question or to the patient's lab values for today's follow-up visit, and you've already made up your mind how to answer, how to make a clinical decision. Good. Okay. How about group 8? I want you to teach me what this slide is. As if you were giving this lecture, I want you to teach me this. Actually, you know what? Just to make sure we have time to finish everything, I'll let y'all look there. But I will ask you this. Why do NSAIDs have a black box warning for patients with heart disease? My next question is going to be, why are ACEs and ARBs considered renal protective? Right? I remember back when I graduated pharmacy school, I had to take an exam to get licensed, and I had a picture of a nephron, and I had an NSAID, and I had an ACE inhibitor, and I had to drag it into the part of the nephron where the drug acted.
What?
Why?
I'll let you do with that information what you wish. Right? NSAIDs, right, block prostate, causing vasoconstriction. Right? If you vasoconstrict your afferent arteriole, you are going to get less fluid into your kidney. Right? So one, that decreases the pressure that's inside your glomerulus. Right? So you decrease the pressure in your glomerulus because you cause afferent vasoconstriction. You decrease your filtration, your GFR, your serum creatinine will go up. You could have a kidney injury. But also, you have reduced your filtration in your kidney at the expense of causing fluid overload, right? Because you're blocking fluid from coming into your kidney to get filtered. So you got patients with heart disease, they're already susceptible to one kidney injury, they're on ACE inhibitors, etc., and they are also pretty susceptible to fluid overload, right? ACE inhibitors and ARBs are renal protective because they vasodilate your efferent renal arteriole. Right? So they also reduce the pressure in your kidney, but they do it, your creatinine will go up, right? As long as it's less than 30%, we're okay with that. But when you reduce that high pressure system in your glomerulus, you are, yes, reducing filtration, but you're removing that added pressure to your kidney so that your kidney disease does not progress as quickly. Does that make sense?
Can you explain that again?
ACEs and ARBs act on your efferent arteriole, and they take your 2-lane highway to a 6-lane highway. So traffic moves more freely through your nephron. Yes, your creatinine goes up because you are clearing less. Right? Your traffic is able to flow more freely, so less people are frustrated to get off the interstate. But it reduces the pressure, and so it prevents your kidney disease from progressing as quickly. NSAIDs take your 6-lane highway on your efferent, on your afferent arteriole, and turn it into a 2-lane highway. So now you got 2 lanes coming in and 2 lanes coming out. So there's less people even getting into your nephron to get pissed off at traffic and to get filtered, right? And there's a whole lot more traffic backed up into your heart, into your lungs, into your rest of your systemic circulation, causing you to be fluid overloaded and at risk for cardiac injury.
Thank you.
Yes, ma'am. So, don't leave. I'm going to ask you questions, or I'm going to ask if there's any questions from you guys for the next minute or so, and then we will have a short quiz before you guys leave. So, any questions from the Augusta campus? Any questions from the Savannah campus? No, sir. And from the Athens campus?
Don't think so.
Okay. Anybody here in Albany have any questions? Can you guys see that there's a quiz active in ELC? It is active now? Yeah? Okay. Quiz password is nephrology. Please be reminded of the honesty, the UGA dishonesty policy and academic dishonesty or whatever that thing is. Don't cheat. If you were in class and you listened to anything, you should be perfectly fine. And after you finish the quiz, you guys are free to roll. Have a great weekend.